Hello everyone, let's do some passmed questions. So a 49-year-old man is brought to ED after he was found on the side of the road unconscious. The paramedics gave a history of alcohol abuse. You asked the nurse to perform a set of basic observations: capillary blood glucose and an ECG. His basic observations are a temperature of 35.9, that's hypothermia, blood pressure of 190 over 110, that's high, heart rate of 51, that's low heart rate, respiratory rate of 24, that's high. Stokes breathing, what does that mean? And oxygen saturation's 95% on air. His Glasgow Coma scale is 4 out of 15, E1, V1, M2. It's very low. Capillary blood glucose comes back as 10.1, slightly high. The ECG shows T-wave inversion in all leads and QT prolongation. What's the most likely diagnosis? The options include head injury, hypothermia, ischemic stroke, non-ST elevation MI, and ST elevation MI. So T-wave inversion in all leads and QT prolongation. There was no mention of ST elevation, so ST elevation MI is out. It's just found unconscious. Blood glucose is slightly high. He does have hypothermia, but is that the main thing? Hypothermia, the respiratory rate should be low as well, right? Not so sure. My impression is that if you are hypothermia, you have low heart rate, low respiratory rate, everything is slowed down. But in this case, he has high blood pressure and high respiratory rate. And then there's another thing here to notice is the blood pressure is very high and the heart rate is very low. This is this part of the signs of increased intracranial pressure. What's this thing called? Cushing's triad or something like that. Stokes breathing might be the breathing where you have irregular pauses in between. That was part of the Cushing's triad as well. Now this happens because of head injury. So I'm gonna put head injury. Plus GCS is so low. All this could cause low GCS anyway. The answer is head injury. Global T-wave inversion not fitting with a coronary artery territory. Think non-cardiac cause of abnormal ECG. Head injury. Given the scenario, it's very likely this patient in question has a fall secondary to alcohol intoxication. Where? Oh, okay, he has a history of alcohol abuse. His observations represent Cushing's triad: hypertensive, bradycardic, tachypnic, with signs of Stokes breathing, and are a sign of brain herniation. This is also confirmed by ECG showing widespread T-wave inversion, also known as cerebral T-waves. QT prolongation is another finding on this ECG that is in keeping with the clinical picture. Hypothermia is defined as core body temperature of less than 35, okay. So this is not yet hypothermia. It is 35.9. By definition, it has to be below 35. An ECG would not show T-wave changes, but may show QT prolongation along with other hypothermic changes. Ischemic stroke. ECG abnormalities secondary to ischemic stroke are very unusual. A patient's clinical picture is the indicator through which investigation results need to be interpreted. However, massive ischemic strokes, middle cerebral artery occlusion, causing cerebral edema may result in these ECG findings as a result of raised intracranial pressure. Non-STEMI. Since we cannot obtain a history from this patient, it is reasonable to include NSTEMI amongst the preliminary differentials. However, the widespread nature, not fitting a specific coronary region, and the clinical picture should sway you away from this differential. STEMI, there are no ST elevations. Okay. Next question. An 80-year-old lady presents with a 5-day history of painful left-sided neck swelling below the angle of the jaw. She also complains of a foul taste in her mouth. On examination, she has a temperature of 37.8 and 4 × 5 cm submandibular mass, which was tender to palpation. There is associated tender lymphadenopathy. What's the most likely diagnosis? So she has a 5-day history of painful left-sided neck swelling below the angle of the jaw. Complains of foul taste in her mouth. Temperature is slightly high. 4 × 5 cm for a 5-day history is quite acute. Tender to palpation. Sounds like an infective thing. There is associated tender lymphadenopathy, signifying further that this could be an infection. What's the most likely diagnosis? Lymphadenitis. It's inflammation of the lymph nodes. Well, she does have lymphadenitis since she has tender lymph nodes. But what is the 4 × 5 cm submandibular mass here? One clue is there's a foul taste in her mouth. It could be something related to her. What's under your mandibles here? Submandibular glands. Could be something wrong with submandibular glands. So viral parotitis. Parotitis is inflammation of the parotid glands, which is on your cheek, not on your submandibles. Sjogren's syndrome. Sjogren's syndrome usually causes inflammation of the salivary ducts, which cause you to have very dry mouth, dry eyes, because it prevents secretion of your saliva. Sialadenitis is the most likely malignancy. C is unlikely for a 5-day history, such an acute presentation. So I'm gonna go for sialadenitis, means inflammation of your salivary glands. Saliva, refer to glandular cells. Itis refers to inflammation. And the answer is sialadenitis. This lady has sialadenitis, inflammation of the salivary gland, likely secondary to obstruction by a stone impacted in the duct. Oh, okay. Stone, huh? The duct from the submandibular gland drain into the floor of the mouth, and purine discharge from this duct causes a foul taste in the mouth. There are 3 main salivary glands. The parotid glands are anterior and inferior to each ear. The submandibular gland lies below the angle of the jaw. The sublingual glands lie beneath the tongue. Disorders of these glands occur due to infection, inflammation, obstruction, or malignancy. Submandibular gland causes of swelling of this gland include obstruction with a stone or tumor. Can be benign or malignant. Alright, next question. You review a 68-year-old lady in neurologic clinic with a diagnosis of Parkinson's disease. You note as she enters the room that she walks slowly with her arms by her side. She has a characteristic tremor and is lifting her left foot higher than the right. She has some difficulty initiating the conversation. Which of the following is due to a condition other than the patient's Parkinson's disease? So, Parkinson's disease features include tremor. It's a resting tremor. Bradykinesia. You have a shuffling gait. You have masked faces. What else do you have? So let's see. Walks slowly with her arms by her side. This could be the shuffling gait and the bradykinesia. She has a characteristic tremor. This is the resting tremor. It's part of Parkinson's. Lifting her left foot higher than the right. This is not characteristic of Parkinson's. This could be high stepping gait. because of a foot drop or something. Or she cannot feel, so she step harder. She has some difficulty initiating the conversation. That's part of Parkinson's also, I think, because you have the problem with changing directions when you're walking as well. So initiating a conversation is part of initiating something. So it's part of Parkinson's as well. Which of the following is due to condition other than patient's Parkinson's disease? Reduced arm swing is part of Parkinson's disease. Steppage gait is not, I think. Steppage is the bringing the foot higher. It's not part of it, I think. Depression. Anybody with a chronic disease could have depression. Speech disturbance. Speech disturbance. I think it's part of Parkinson's as well. Unilateral. Parkinson's disease should have symmetric tremor, right? Why is it unilateral? Or could they have unilateral tremor as well? And I'm gonna guess steppage gait because I only know shuffling gaits for Parkinson's. Steppage, not something I know Parkinson's has. Okay, steppage gait is characterized by a high step due to foot drop and loss of ability to dorsiflex the foot. Unilateral tremor is seen initially in Parkinson's prior to it becoming bilateral, I see. Depression, reduced arm swing, and speech disturbance are also features of Parkinson's disease. Okay. Yeah, the other features of Parkinson's. Right, next question. A 60-year-old man comes to his GP. He has had a series of unpleasant symptoms over the last 2 months, including frequent flushing, diarrhea, tightness in his throat that sounds to the GP like bronchospasm, and weight loss. The GP also notices he is hypotensive. Which of the following investigations is the best for diagnosing the condition you suspect? So what do we suspect first? Unpleasant symptoms for the last 2 months. Flushing, diarrhea, tightness in his throat that sounds like bronchospasm. So weight loss is a sign of malignancy in a 60-year-old man as well. Higher risk of malignancy. Hypotensive. Sounds like a neuroendocrine tumor that secretes probably serotonin, which causes the vasodilation and facial flushing, the diarrhea, the bronchospasm. Could be due to prostaglandins. Weight loss probably due to the cancer cells taking up all the nutrients that should be taken by his normal cells. Hypotensive probably due to the vasodilation as well, caused by serotonin probably, or other vasodilators. Which one is for a neuroendocrine tumors? CA125 is for ovarian cancer, I think. MRCP, magnetic resonance cholangiopancreatography, is for visualizing the bile and pancreatic ducts. Wouldn't diagnose a neuroendocrine tumor. Ultrasound of the abdomen, I think this would be first line to look for any masses, but might not be able to diagnose it. Urine 5-HIAA, what's that? A metabolite of some serotonin or something. I think this could be it. Urinary metanephrine is a metabolite of adrenaline, or usually used to diagnose pheochromocytoma, so probably not. I'm gonna guess urinary 5-HIAA, and that's the correct answer. Oh, it's a carcinoid syndrome, is it? Okay, carcinoid tumors release serotonin, so will cause raised urinary 5-HIAA. There's a typical history of carcinoid syndrome: flushing, diarrhea, bronchospasm, hypotension, and weight loss. The investigation for this is urinary 5-HIAA, as a tumor will secrete serotonin. CA125 is used for ovarian cancer, which this man obviously does not have. MRCP will be used for gallbladder or pancreatic conditions, and urinary metanephrines are used to diagnose a pheochromocytoma. Let's read a bit about carcinoid tumors. Carcinoid syndrome usually occurs when metastases are present in the liver and release serotonin into the systemic circulation. May also occur with lung carcinoid, as mediators are not cleared by the liver. Alright, so the reason carcinoid syndrome only produces symptoms when it metastasizes to your liver is because usually if there's normal carcinoid syndrome and your liver is functioning nicely, then your liver will actually break down the serotonin and you wouldn't see the effects. However, once it spreads to the liver, it impairs your liver function. Your liver doesn't break down the hormones anymore, then you'll have obvious clinical features, then you have obvious symptoms. And there are lungs. Okay, there's lungs. Go direct into your bloodstream without passing through your liver, I guess. Features include flushing, often the earliest symptom, diarrhea, bronchospasm, hypotension, right heart valvular stenosis. Left heart can be affected in bronchial carcinoid. Other molecules such as ACTH and GHRH, growth hormone-related hormone, may also be secreted, resulting in, for example, Cushing syndrome. Pellagra can rarely develop. Pellagra is what? Lack of vitamin B3, is it? Rarely develop as dietary tryptophan is diverted to serotonin by the tumor. Investigation: urinary 5-HIAA. What does 5-HIAA stand for? 5-hydroxyindoleacetic acid. Hydroxyindoleacetic acid is a main metabolite of serotonin. Hydroxyindoleacetic acid. Okay. Plasma chromogranin AY. Management: somatostatin analogs, for example, octreotide. Or for diarrhea, you can give cyproheptadine. What is that? Cyproheptadine. Oops. It's not EMC. I guess they don't have it. Serotonin and histamine antagonist. Okay. It's not a usual drug that you would see. Okay, let's look at this video. Should be helpful. First, I need to change the sound settings so that you can hear it as well. Okay, let's do this.
Carcinoid refers to a specific type of tumour, a carcinoid tumour, which causes neuroendocrine cells to secrete hormones, and this leads to all sorts of symptoms, like diarrhea, shortness of breath, and flushing. So when these symptoms develop as a result of a carcinoid tumour, it's called carcinoid syndrome. So what is a neuroendocrine cell? Well, they're found in tissues throughout the body, and particularly in the epithelial layer of the gastrointestinal organs and the lungs. What happens is they receive signals from nerve cells, and in response, they release hormones into the blood. Neuroendocrine cells release a variety of hormones, and these include amines, like serotonin and histamine, as well as polypeptides, like bradykinin, which is a vasodilator, and prostaglandins, which are also very powerful vasodilators. The production of these hormones can be regulated by other hormones. So, for example, somatostatin is a hormone that's made by cells in the hypothalamus, as well as the gastrointestinal tract, and it travels through the blood and binds to the receptors on the surface of neuroendocrine cells. Binding of somatostatin then inhibits the release of a number of hormones from neuroendocrine cells, including serotonin. Now, when serotonin does get released from neuroendocrine cells, it enters the liver through the portal vein. Once in the liver, some of the serotonin is metabolized into 5-hydroxyindolacetic acid, and that's then eliminated from the body through the urine. But the remaining serotonin is not metabolized, and this portion remains in the systemic circulation, where it has various effects. So let's have a quick look at what this serotonin is getting up to. Well, in the gastrointestinal tract, serotonin increases motility and peristalsis. In the vasculature, platelets take up the serotonin and later use it to constrict blood vessels, particularly after injury. And in the connective tissue of the heart, it stimulates fibroblasts, and these make lots of collagen. Okay, so we get what serotonin does, but where does the tumour side of things come into it? Well, a cell can become cancerous when DNA mutations cause abnormal cellular functions, like uncontrolled, unregulated cellular divisions, which forms a tumour. The limitless replication means that the developing tumour can invade nearby tissue and spread through the blood and the lymph to distant sites in the body, and this is called metastasis. Now, if a neuroendocrine cell mutates and transforms into a cancerous cell, then that cell can continue dividing until it becomes a little mass, and this is a carcinoid tumour. And most of the time, these carcinoid tumours develop in the gastrointestinal tract. Some of the abnormal functions of these cancerous neuroendocrine cells include producing and secreting large amounts of hormones, and, weirdly enough, they also express more somatostatin receptors on their surface, particularly in the gastrointestinal tract, but it's not really known why that happens. Carcinoid tumours tend to be slow-growing, although some can metastasise, often depending on the location. The most common primary sites for carcinoid tumours are someplace along the small or large intestines, as well as the stomach, pancreas, and liver. Also the lungs and the ovaries in females, and the thymus. Whereas the most common site for a neuroendocrine tumour to metastasise to is the liver. So the liver can really be a primary or a secondary site of the disease. And it turns out that metastasis, especially to the liver, is actually often necessary for carcinoid syndrome to occur. And that's because these metastases can lead to liver dysfunction, and this decreases the liver's ability to metabolize the hormones which get released from the neuroendocrine cells. And so they build up, and that can cause symptoms. When we get increased histamine and bradykinin, this can cause vasodilation, which leads to flushing, while histamine can also cause itching. Increased serotonin can cause thickening of the collagen and fibrosis, particularly in the heart valves, which can lead to heart dysfunction, like tricuspid regurgitation and pulmonary stenosis. In the airways, it can cause bronchoconstriction, and this leads to asthma, shortness of breath, and wheezing. The increased synthesis of serotonin also reduces the amount of tryptophan available to the body, which is used to make niacin, or vitamin B3. And reduced levels of niacin can cause pellagra, which is a disease which causes symptoms like inflamed skin and mental confusion. So there's a whole load of excess hormones circulating in the blood, and these lead to a bunch of symptoms. And the most common symptoms of carcinoid syndrome include diarrhea, shortness of breath, flushing, and itching. These symptoms can be worsened by alcohol or emotional stress, since these can further stimulate the neuroendocrine cells. Now, diagnosis of carcinoid syndrome can be made through medical imaging, like a CT scan. Also, something called an octreoscan can help identify carcinoid tumours. And what they do is they inject a radio-labelled somatostatin analogue called octreotide, and this binds to the increased number of somatostatin receptors on tumour cells. There's also urinalysis, which shows increased levels of 5-hydroxyindolacetic acid, while blood tests can show niacin deficiency. When it comes to treatment of carcinoid syndrome, the main aim is to stop hormone production from the neuroendocrine cells. And this can be done with a somatostatin analogue, because these then bind to the somatostatin receptors, and this inhibits the release of hormones. It's also useful to try and decrease emotional stress and alcohol consumption, because this can help limit hormone release. Treatment of the carcinoid tumour itself with surgical resection or chemotherapy can also help to alleviate carcinoid syndrome. So, to quickly go over the main points that we've talked about, carcinoid syndrome, as the word syndrome implies, is a set of symptoms, And these occur as a result of the overproduction of serotonin, histamine, and bradykinin, and this is by neuroendocrine cells, which develop into a carcinoid tumour. The classic symptoms include diarrhoea, shortness of breath, flushing, and itching. Diagnosis can be made with an octreotide scan, as well as elevated 5-hydroxy-indoleucitic acid in the urine and decreased niacin levels in the blood. Hi everyone, Sarah here.
Okay, next question. Respiratory pathogens. For each one of the following scenarios, please select the most likely causative respiratory pathogen. Okay, just remembering stuff. A 14-year-old boy who has a barking cough, which is worse at night. Due to croup, right? Croup is usually due to parainfluenza virus. A 33-year-old man who is known to be HIV positive presents with cough and dyspnea. Auscultation of the chest is unremarkable, but is noted to desaturate on exertion. So desaturate on exertion is like a keyword for PCP, pneumocystis pneumonia, or pneumocystis jirovecii. So what is it caused by? Oh, there it is. A 30-year-old woman presents with a headache, myalgia, fever, and cough. On auscultation, her chest is clear, but she has a temperature of 38.6 degrees Celsius. She has quite a high fever. She has flu-like symptoms. Could be influenza A. Influenza virus. See, yeah. So these are typical flu symptoms. Influenza is much more common than Mycoplasma pneumonia. So it's just memorizing different pathogens and how they present. A 53-year-old Caucasian male presents to his GP for a blood pressure review. He is known to have hypertension and is currently taking Ramipril and Indapamide. Blood pressure taken in the GP clinic is 155/90. What's appropriate management? So if he's 53 years old, he has hypertension, is already taking 2 drugs. Ramipril is an ACE inhibitor and Indapamide is a thiazide-like diuretic. So third drug to add on here, because it's still not under good control, is a calcium channel blocker, such as amlodipine. He has no dry cough due to Ramipril, right? So you don't have to change it to losartan. So this is just memorizing guidelines for hypertension. Yeah, you can go to LICE guidelines and have a look. Over here, nope, is when to treat. Yeah, here it is. So you really need to memorize this table. You can pause the video and have a look. I don't have to because got this question correct. Okay, next question. A 64-year-old male presents to his GP practice with a few months history of weakness. He reports that he first noticed having difficulty opening jars, which has now progressed to difficulty getting dressed. He has also noticed that he is tripping up around the house. His wife, who has attended with him, says that she feels his speech has become slurred on occasion. Examination, the upper limbs you find fasciculations, wasting of small muscles of the hands bilaterally, increased tone bilaterally, power 3 out of 5 in most limb movements. This is against gravity, it's very weak. Brisk reflexes, sensation is normal. Given the most likely diagnosis, which of the following muscles are typically spare? Okay, so first we have to know what's the most likely diagnosis. Human history of weakness. It's all motor symptoms. And tripping up around the house, probably there's a foot drop or legs are weak. Speech. So even his muscles even his facial muscles are affected. On examination of upper limbs, you'll find fasciculations. Fasciculation is signs of, I think fasciculation is a sign of lower motor neuron lesion, wasting of small muscles of the hands bilaterally, probably either due to reduced innervation or disuse, atrophy. Increased tone bilaterally. Increased tone is more of an upper motor neuron lesion. It's raining. Well, okay. Power 3 out of 5 in most limb movements. That's only against gravity. 4 out of 5 is weakness. 3 out of 5 is against gravity. 2 out of 5 is... Wait. 2 out of 5 is against gravity, right? Brisk reflexes. I can't remember what each of the power means. I have to revise that. Brisk reflexes is an upper motor neuron lesion. Sensation is normal, so only motor neurons are affected. Likely this is motor neuron disease then. Even the most likely diagnosis, regional flowing muscles are typically spared. In motor neuron disease. Ocular muscles. I don't know. Facial muscles, no, since he has difficulty talking already. Respiratory muscles probably will be affected later on, but then Stephen Hawking has motor neuron disease and he doesn't need a ventilator, right? Probably respiratory muscles, maybe. Tibialis anterior is in your foot. He already has a foot drop, so that's definitely affected. Ocular muscles, small muscles of the hands is already affected since it started with difficulty opening jaw. So I'm torn between respiratory muscles and ocular muscles. I'm gonna guess respiratory muscles because I don't remember Stephen Hawking needing ventilators. I don't know about his eye movements. Let's see. Nope, the answer is ocular muscles. Eye movements are typically spared in motor neuron disease. The correct answer is ocular muscles. Eye movements are typically spared in motor neuron disease. Slurred speech and difficulty swallowing are common in motor neuron disease, as muscles of the face, the tongue, and the throat are often affected. Respiratory muscles are commonly affected, leading to shortness of breath and sometimes requirement for ventilation. Wasting of small hand muscles and tibialis anterior are common in motor neuron disease, and this can be common examination findings. So see, motor neuron disease. Turn on the aircon. Motor neuron disease features. Motor neuron disease is a neurological condition of unknown cause which can present with both upper and lower motor neuron signs. It rarely presents before 40 years, and various patterns of the disease are recognized, including amyotrophic lateral sclerosis, progressive muscular atrophy, and bulbar palsy. Unknown cause which can present with both upper and lower motor neuron signs. It rarely presents before 40 years. If I'm not mistaken, fasciculations is a lower motor neuron sign, right? Fasciculations, lower motor neuron disease. Okay. And the other thing I want to find out is power. So, kinematics. 0 is no contraction. 1 is flicker or trace of contraction. 2 is active movement with gravity eliminated. It's sideways movement. 3 is against gravity. 4 is against gravity and resistance, but weakness. 5 is normal power. 3 is against gravity. 2 is not against gravity, sideways. 1 is just flickers, trace of contraction. Okay, gotta remember that. Flicker, sideways, no movement, 0, no contraction. Okay. Let's read a bit about motor neuron disease. Features include motor neuron disease is a neurological condition of unknown cause which can present with both upper and lower motor neuron signs. It rarely presents before 40 years, and various patterns of disease are recognized, including amyotrophic lateral sclerosis, progressive muscular atrophy, and bulbar palsy. Don't mind the lights turning on and off. It's because it's raining heavily and house electricity is tripping. Right. There are a number of clues which point to a diagnosis of motor neuron disease: fasciculations, the absence of sensory signs or symptoms, the mixture of lower motor neuron and upper motor neuron signs. Wasting of the small hand muscles tibialis anterior is common. Other features doesn't affect external ocular muscles, no cerebellar signs. Abdominal reflexes are usually preserved, and sphincter dysfunction is present as a late feature. The diagnosis of motor neuron disease is clinical, but nerve conduction studies will show normal motor conduction and can help exclude a neuropathy. Electromyography shows a reduced number of action potentials with increased amplitude. MRI is usually performed to exclude the differential diagnosis of cervical cord compression and myelopathy. Vague sensory symptoms may occur early in the disease, for example, limb pain, but never sensory signs. Okay, next question. A man in his 50s presents with a lump under both his nipples. So having gynecomastia, he is very embarrassed and states he no longer takes his shirt off in public anymore. Currently, he is taking 5 medications, which include metformin, ramipril, ketoconazole, glycoside, and cocodamol. What could be the culprit here? Which of the following is the most likely cause of his presenting complaint? Ramipril, metformin, glycoside, cocodamol, not known to cause gynecomastia, I think. But ketoconazole, I'm not so sure. So I'm gonna go for ketoconazole. It's an antifungal. Let's look here. Side effect of ketoconazole is gynecomastia. Ketoconazole has a clear link with gynecomastia. It does this by suppressing the production of androgens. Patients may have reduced level of testosterone. All the other drugs are not clearly linked with gynecomastia. Let's look at the short notes on ketoconazole. The August 2013 issue of the Drug Safety Update carried a warning on the use of oral ketoconazole due to the high risk of hepatic toxicity ranging from hepatitis to cirrhosis or liver failure. It advised against the use of oral ketoconazole completely. So no more oral ketoconazole. What's he taking? Topical? This does not affect the prescription of topical ketoconazole, which is still safe. There's no systemic absorption. Next question. Primary biliary cirrhosis is most characteristically associated with the semantic memory. PBC, primary biliary cirrhosis. This is the one more common in female. Associated with the answer is antimicrobial mitochondrial antibodies. Primary biliary cholangitis, the M rule. We have IgM, we have anti-mitochondrial antibodies on the M2 subtype, and you have middle-aged females. IgM, anti-mitochondrial antibodies. Okay, what M's? M rule. M anti-mitochondrial antibodies of the M2 subtype and middle-aged females for primary biliary cholangitis. Okay, maybe we can look at the notes and watch this video to consolidate our memory. Primary biliary cholangitis. Primary biliary cholangitis, previously referred to as primary biliary cirrhosis, is a chronic liver disorder typically seen in middle-aged females. Female to male ratio of 9:1, so much more common in females. The etiology is not fully understood, although it is thought to be an autoimmune condition. Interlobular bile ducts become damaged. reached by a chronic inflammatory process causing progressive cholestasis, which may eventually progress to cirrhosis. The classic presentation is itching in a middle-aged woman. Associations include Sjogren's syndrome seen in up to 80% of patients. That's quite high correlation. Rheumatoid arthritis, systemic sclerosis, thyroid disease, or autoimmune diseases. Clinical features include may be asymptomatic, for example, raised ALP on routine LFTs, or fatigue, or pruritus, or pruritus, cholestatic jaundice, hyperpigmentation, especially over pressure points. Around 10% of patients have right upper quadrant pain. Xanthelasmas, xanthomas, also clubbing, hepatosplenomegaly. Late features may progress to liver failure. Diagnosis: we have anti-mitochondrial antibodies, AMAs, of the M2 subtype, present in 98% of patients, so it's quite sensitive, and are highly specific as well. Smooth muscle antibodies in 30% of patients, and raised serum IgM. Management first line is with ursodeoxycholic acid. That's a bowel questions or something. It liquefies the bowel, something like that. Slows disease progression and improves symptoms. Pruritus, you can give cholestyramine, which is an antihistamine, I think. Let's look for each of this now. Oh, I got no internet now, huh? My connector hotspot. It's my phone. Hold on now. Pause the recording. This back with internet connection. Where were we? So we wanted to look at the mechanism of action of ursodeoxycholic. Ursodeoxycholic acid. PBC, other hepatobiliary disorders. The bile acid preparation. UDCA is a bile acid which affects the reduction by dispersing the cholesterol and forming a liquid crystal phase. So reduces cholesterol in biliary fluid by dispersing the cholesterol and forming a liquid crystal phase. Okay, what about the other drug, cholestyramine? It's an antihistamine, right? Wait, cholestyramine anhydrous, is this the correct thing? Bile acid sequestration. Oh, okay, it's not an antihistamine. Cholestyramine resin absorbs and combines with the bile acids in the intestine to form an insoluble complex which is excreted in the feces. This results in a continuous, though partial, removal of bile acids from the enterohepatic circulation by preventing their reabsorption. Okay, the increased fecal loss of bile acid is to an increased oxidation of cholesterol to bile acids and a decrease in serum cholesterol levels and low density lipoprotein serum levels. Cholestyramine is hydrophilic, but it's not soluble in water, nor is it hydrolyzed by digestive enzymes. Not soluble in water, nor is it hydrolyzed by digestive enzymes. Patients with partial biliary obstruction, reduction in serum bile acid levels reduces excess bile acids deposited in the dermal tissue and resultant decrease in pruritus. Right. This is a bile acid sequestrant which causes bile in your intestine to be insoluble, hence you don't reabsorb it. And then you can give some fat-soluble vitamin supplementation because the bowel secretion is impaired, and then liver transplantation, bilirubin, more than 100 ppc is major indication. Recurrence in graft and can occur, but it's not usually a problem. Complications include cirrhosis, portal hypertension, ascites, variceal hemorrhage, osteomalacia, and osteoporosis, probably because lack of vitamin D. Those fat-soluble vitamins include A, D, E, and K. D is important for your bones. Significantly increased risk of hepatocellular carcinoma, 20-fold increased risk. It's quite high. Let's have a look at the osmosis video on PBC.
Primary biliary cholangitis and cirrhosis, sometimes just shortened to PBC, is this autoimmune disease where the T cells attack the cells that line the smaller-sized bile ducts in the liver. As the cells are damaged or destroyed by immune attack, they start letting bile leak through their tight junctions and into the interstitial space, where it can get into the blood and other liver cells. This can cause inflammation and symptoms that are similar to cholestasis and obstructive jaundice, both of which there's this disturbance in bile flow. At first it presents as chronic inflammation, which is where it gets the name cholangitis, for inflammation of the bile ducts. But advanced stages of the disease leads to cirrhosis as more cells are destroyed, both from the autoimmune attack and from infiltration of bile. As with a ton of autoimmune diseases, the exact reason why these T cells start attacking these bile duct cells is unknown, and it's likely related to genetic predisposition in combination with environmental triggers, and is associated with other autoimmune diseases like autoimmune hepatitis and Sjogren's syndrome. And PBC tends to affect women at a much higher rate than men, at about a 9-to-1 female-to-male ratio. For some reason that is yet to be completely figured out, in almost all cases of PBC, your body creates antibodies to mitochondria, specifically a mitochondrial protein called PDC-E2. For that reason, one of the most notable markers in PBC are these anti-mitochondrial antibodies, or AMAs, in the patient's blood. As many as 95% of patients with PBC have these AMAs in their blood. Why, though, are the bile duct cells specifically targeted? Don't all cells have mitochondria? Shouldn't these AMAs be targeting all cells then? Well, one theory is based on a concept called molecular mimicry, where the antigens that bring about this autoimmune response are really similar to another protein, but different enough so that the immune system gets confused and thinks it's a foreign version of that particular protein. As an example, here's two people's cells. They both have this triangle protein, but they have different colored triangles. Each person's immune system knows that these are their own proteins, their own self-proteins, that they shouldn't attack, but they have antibodies for proteins that are very similar, but definitely different from self-proteins. So like person A has red, yellow, and blue, but just not green, and person B has green, yellow, and blue, but not red. So both these people's immune systems are like, yep, these are all self, so we're good here. But now say person B's red triangle turns into a green triangle instead. The immune system's like, weird, that's not red. That must not be ours. And so the green triangle antibody binds it, and the immune system kicks in, destroys the cell, and starts making a ton of these matched antibodies. So now applying this concept to PBC, you've got these AMAs for foreign versions of the PDC-E2 protein in your mitochondria. So like maybe your PDC-E2 is a red triangle. So you don't have the antibodies to the red triangle PDC-E2 because your immune system knows that red equals self. So the theory is, and mind you that this is definitely a theory, on why patients with PBC have a ton of these AMAs in their blood for this PDC-E2, is that some infection, or maybe a chemical in the bile ducts, an environmental trigger of some kind, damages a bile duct cell in such a way that now it shows this protein that happens to be really similar to PDC-E2 in structure. So maybe it's a triangle, but it's different enough to be non-self. So maybe it's a green triangle instead of a red triangle. And this triggers an immune response to this particular green triangle protein, which remember is similar but not the same as the red triangle protein in the mitochondria. And so the immune system starts pumping out these green triangle anti-mitochondrial antibodies, or AMAs, even though the target antigen isn't even necessarily from the mitochondria. It's just sort of mimicking the structure of the mitochondrial protein. Wild, huh? That's the theory anyway, and sort of helps explain why just the bile duct cells are being attacked, and not just all cells in general. As to the complications, a lot of the clinical findings are related to the leakage of bile and general inflammation of liver tissue. For example, jaundice typically happens after most of the bile duct cells have been destroyed, since now the bile and conjugated bilirubin is leaking into the blood, right? Similarly, other things in the bile can get into the blood as well, like cholesterol. Cholesterol can deposit in the skin over time and lead to xanthomas. But for reasons that aren't super clear, a lot of patients actually get pruritus, or itchy skin, even before the jaundice sets in and the bile salts get a chance to deposit in the skin. Again, it's unclear what causes this early itchiness, but eventually as bile leaks into the blood, bile salts will also contribute to the pruritus and itchiness. A high proportion of patients also have joint pain and arthropathy, which may be connected to other autoimmune diseases like rheumatoid arthritis. In addition to these AMAs and components of bile getting into the blood, it's also pretty common to find both alkaline phosphatase and gamma-glutamyl transpeptidase, or ALP and GGT. Both of these are normally found in the bile duct cells, so when those cells get damaged or die, these enzymes can be released and get into the bloodstream. Ultimately, the issue with PBC is that over time the immune cells wreak havoc on the bile ducts, and all this bile leakage slowly but surely damages the liver and surrounding tissue, and gets into the blood. A couple medications can be used to help kind of reduce these symptoms of bile components like cholesterol getting into the blood. One is ursodeoxycholic acid, which reduces the body's absorption of cholesterol, and the other is cholestyramine, which binds to cholesterol and allows it to be more easily excreted. And finally, if the damage to the liver has gotten severe enough, a liver transplant might be recommended. One last thing, if damage has been done to these bile duct cells, but the cause isn't due to an autoimmune attack, like maybe if the ducts are obstructed for a long time by a tumor or something, then it'd be called secondary biliary cholangitis and cirrhosis. Secondary PBC would present with a lot of the same symptoms and complications that crop up from bile being released from the bile ducts, right? But one very important difference is that there wouldn't be any antibodies to mitochondria in the blood, right?
Okay. Right, next question. A 13-year-old boy presents to the emergency department following an overdose of paracetamol. He has presented 2 days after he took the overdose and he is feeling incredibly unwell. Which of the following patterns of liver disease are you most likely to see? It would cause high ALT, high ALP. ALT should be higher than ALP. High ALT, high ALP, ALT to ALP ratio high, that's correct. High ALT, normal ALP, ALT to ALP ratio high could also be correct. So ALP is more of a bile duct thing, but I think liver cells also has ALP. So it should be both ALT and ALP are high. Might be wrong, it's between this and this. No, so I was wrong. The answer is normal ALP. Paracetamol overdose causes hepatocellular picture of liver disease. This question requires an understanding of the different types of liver disease. They can effectively be split into hepatocellular, cholestatic, or mixed. Cirrhosis is arguably a separate category of liver disease as well. The following table shows the expected liver function tests that would be seen in each disease. ALT would be raised at least 2-folds for hepatocellular disease. Would be normal in cholestatic disease. Would be raised at least 2-folds in mixed disease. ALP would be normal in hepatocellular disease, raised at least 2-folds in cholestatic disease, raised at least 2-folds in mixed disease. ALT to ALP ratio will be 5 plus for hepatocellular disease, less than 2 for cholestatic disease, and 2 to 5 for mixed disease. AST and ALT are both produced by hepatocytes. AST and ALT, not ALP, huh? In hepatocellular disease, hepatocytes release these enzymes into the bloodstream, hence explaining the raised ALT in this question. ALP is produced by the cells lining the bile ducts, so no ALP in the hepatocellular cells. Hence, the levels in the blood will rise in obstructive disease. Okay, next time I know ALP should be normal. Next question. A 24-year-old woman presents to the emergency department with a 1-day history of nausea and severe constant pain, localized since onset to the left iliac fossa. She had vomited once but has no other symptoms. She has a 28-day menstrual cycle. Her last menstrual period started 7 days ago. She's sexually active and has always used condoms for contraception. There is no vaginal bleeding. What is the most likely diagnosis? Nausea, severe constant pain, left iliac fossa. Could be ectopic, could be ovarian torsion, could be ruptured ovarian cyst, something so acute. What else could it be? Appendicitis? Still could be appendicitis. Wait a minute. This is left iliac fossa. So it's where the descending colon is. Your appendix is not there unless there's cytosis. Less likely appendicitis. She had vomited once but no other symptoms. She has 28-day menstrual cycle. Last menstrual period started 7 days ago. So she just had a period. It's unlikely that she's pregnant because menstruation 7 days ago started 7 days ago. Menstruation usually lasts 3, 4, 5 days maybe. Now it's just about 2 to 3 days after her menstrual period. Probably ovulation has not occurred yet. Ovulation usually happens on around day 14 in a 28-day cycle. So what is going on? Middle smirks, like I said, ovulation usually occurs on day 14. Middle smirks is like ovulation pain, I think. Ectopic pregnancy is unlikely since there's no ovum. Likely no ovum. Still, a urine pregnancy test should be done just to be safe. Appendicitis on the left side, less likely. Ovarian torsion is a possibility. Pelvic inflammatory disease wouldn't be so acute. Be more central rather than left or right. So I'm gonna go with ovarian torsion. Yep, and the answer is ovarian torsion. Ovarian torsion is the most likely diagnosis. This is common in women of reproductive age. Ovarian torsion is associated with iliac fossa pain that can radiate to the loin, groin, or back. Nausea and vomiting are commonly associated symptoms. On examination, the patient may have an adnexal mass, which is commonly an ovarian cyst or a neoplasm, which has disrupted the normal lie of the ovary to cause the torsion. Patients also sometimes present with low-grade fever, especially for longer durations of torsion where ovarian necrosis may be present. Ectopic pregnancy is an important differential which should be ruled out with a pregnancy test in all women regardless of reported contraception. The presence of vaginal bleeding may help to differentiate these two conditions clinically since the menstrual period starts 7 days ago and this patient uses condoms for contraception. Ectopic pregnancy is less likely than ovarian torsion. Appendicitis is to be considered as a cause for this presentation, but usually presents with a diffuse abdominal pain that later localizes the right iliac fossa, and appendicitis pain can be reproduced by the right iliac fossa. In the right iliac fossa by palpation, the left iliac fossa, which is known as a Rovsink's sign, but left iliac fossa pain would not be the presenting symptom. Middle smokes could cause right iliac fossa pain, but this would be mild and not associated with nausea and vomiting. And pelvic inflammatory disease will develop chronically and is unlikely in a woman who has always used condoms. Let's look at what is Mr. Smirks. Mr. Smirks. So one-sided lower abdominal pain associated with ovulation. Yeah, so it's ovulation pain about 14 days before your next menstrual period. Wouldn't be this severe. Right, next question. A 79-year-old woman with a known history of hypertension, gout, and complex regional pain syndrome, CRPS. Oh, okay. Is recovering on a ward following a total hip replacement for a subcapital fracture, neck of femur. Subcapital is an intra-articular fracture. Drug history includes amlodipine, 10 mg OD, allopurinol 100 mg OD, pregabalin 150 mg BD, and paracetamol 1 gram QDS. She is on patient control analgesia (PCA) pump, which she uses for regular administration of IV morphine. She calls the ward sister complaining of suprapubic pain and an inability to pass urine, which medication is most likely to have caused these symptoms. So let's look at each of her medications. The medications include amlodipine, which is a calcium channel blocker, shouldn't have anything to do with urinary retention. Allopurinol is for gout, I think. It's for chronic management gout. Is it a xanthine oxidase inhibitor? I gotta check. Pregabalin is for neuropathic pain. For neuropathic pain, does it have an effect on your urinary retention? GABA, pregabalin, GABA. Maybe. I'm not sure about this one. Paracetamol definitely wouldn't cause urinary retention. Patient control analgesia for morphine. Morphine would cause constipation. Constipation could cause urinary retention if the impaction of stools compresses on the urethra, but that's a long shot. Could be the pregabalin. Neuropathic pain. I'll go with pregabalin because I'm not very sure about morphine either, but usually it's more constipation than urinary retention. Let's see. Oh, so the answer is morphine. Right. Opioid analgesia is a common cause of urinary retention. Opioids such as morphine are a common cause of urinary retention. Given also that morphine is a medication that was newly started, this is more likely to be the cause of the patient's urinary retention. The patient will need a two-way catheter initially to relieve her symptoms. The medications which are known to cause urinary retention include tricyclic antidepressants, anticholinergics, opioids, NSAIDs, and disopyramide. Allopurinol is known to cause toxic epidermal necrolysis, TEN, as a rare side effect. It does not cause urinary retention. Amlodipine is a calcium channel blocker used in the treatment of hypertension. It's not known to cause urinary retention. Common side effects like swelling. Paracetamol is generally very safe medication. It's not known to cause urinary retention. Half the dose is given to those with renal impairment and those weighing under 50 kgs. Pregabalin is primarily used for neuropathic pain. It rarely causes urinary retention but can cause drowsiness, dry mouth, mood disturbances. Right, drug-induced urinary retention of flowing drugs may cause urinary opioids is one of them. Alright, so there's something new. Opioids can cause urinary retention, not just constipation. I wanted to look for the mechanism of action of allopurinol. So this allopurinol, it's used for reducing uric acid, renal stones, calcium oxide renal stones. It's used in gout as well, I think. Pharmacodynamics is anti-gout preparation inhibiting uric acid production. Allopurinol is a xanthine oxidase inhibitor. Allopurinol and its main metabolite, oxypurinol, lower the level of uric acid in plasma and urine by inhibition of xanthine oxidase, the enzyme catalyzing the oxidation of hypoxanthine to xanthine and xanthine to uric acid. In addition to the inhibition of purine catabolism in some but not all hyperuricemic patients, de novo purine biosynthesis is depressed via feedback inhibition of hypoxanthine guanine phosphoribosyltransferase. Other metabolites of allopurinol include allopurinol ribose and oxypurinol 7-riboside. Okay, so it's a xanthine oxidase inhibitor, and the pathway is from hypoxanthine to xanthine to uric acid. So it inhibits all these processes. It's a long-term management for gout, not for acute management. Right, what else did I want to find out? Mechanism of action of pregabalin. So this is pregabalin. Therapeutic indications for neuropathic pain, epilepsy, generalized anxiety disorder. Pharmacodynamics. It's an anti-epileptic active substance. Pregabalin is a gamma aminobutyric acid. So GABA, right? Yeah, so it's GABA analog. It's a GABA analog. GABA is something that blocks stuff, especially your glutamate. Blocks transmission of neurons. Pregabalin binds to auxiliary subunit of alpha-2 delta protein, a voltage-gated calcium channel, of voltage-gated calcium channels in the central nervous system. So it blocks neurons firing. But it doesn't particularly block cholinergic. How about morphine? How does that cause urinary retention? Morphine is pharmacologically the most important alkaloid of opium. It's used primarily as an analgesic for severe pain. The analgesic effect of morphine is primarily due to interaction with the OP3U receptor. mu receptor, I think. One of the three major classes of opioid receptors that can be distinguished in the central nervous system. The metabolite morphine 6-glucuronide acts as an agonist on opioid receptors and contributes significantly to the pharmacological effects of chronic morphine treatment. Doses of 0.1 mg per kg body weight of morphine and higher are effective in various animal analgesic tests. Morphine causes respiratory depression by diminishing the response of the respiratory centers to CO2. The effect is mediated by the action of OP3 receptors and can be antagonized by naloxone. Morphine stimulates the chemoreceptor trigger zone by action of dopamine receptors and may cause nausea and vomiting. Other effects: morphine can induce euphoria and meiosis. Hypotension may occur due to increased histamine release, especially in hypovolemic patients. No mention of urinary retention. Yeah, it does cause urinary retention, hesitancy, oliguria, loss of libido. Okay. Does cause constipation as well. It just blocks stuff. Oh well. Something else to memorize other than constipation can cause urinary retention as well. A 50-year-old diabetic woman is admitted to the day surgery unit for an elective incision and drainage of groin abscess. Her diabetes is usually well controlled on metformin. What should be done with regard to her diabetic control? Usually well controlled on metformin. What should be done with regard to her diabetic control? Does she need to stop metformin temporarily for this procedure, the incision and drainage? Probably not. Sounds very small surgery. Let's try continue. Yeah, so that's the correct answer. The patient is an orally controlled diabetic and therefore is unlikely to need a sliding scale regimen unless it's particularly major surgery, which an incision and drainage is not. If the patient was undergoing significant surgery, then they would usually be admitted the night before and commence on variable rate infusion. Delaying surgery is not normally advised unless there are significant contraindications. This type of surgery is likely to be a day case and therefore she can continue on the normal metformin regimen. It's because this surgery is not that big of a surgery, right? A 31-year-old woman presents to her GP with progressively worsening menstrual pain that usually commences a few days before her period. She tried to take paracetamol and ibuprofen to alleviate the pain, but they are not effective in doing so. She also describes extreme discomfort when she has penetrative sex. So, could be endometriosis so far. Endometriosis, because endometriosis could be in the cervix, causing deep dyspareunia, could be in the pouch of Douglas, causing deep dyspareunia as well, and it is a cause of secondary dysmenorrhea, which is typically pain before the period starts. Digital vaginal examination reveals nodularity and marked tenderness in the posterior fornix of the cervix. Probably there's some endometrial tissue there. Bimanual examination reveals a fixed retroverted uterus. I think normally is antiverted and antiflex. That's the most common anatomy. Retroverted is a normal anatomical variant. Given the likely diagnosis, which are flowing investigations is considered a gold standard. Likely diagnosis. So the likely diagnosis is endometriosis, right? And the gold standard investigation would be laparoscopy. Put the camera in and then look for endometrial tissue. Yep, laparoscopy is the gold standard investigation for patients with suspected endometriosis. The diagnosis here, given the description of severe dysmenorrhea which does not respond to NSAIDs and deep dyspareunia, is endometriosis. This condition commonly affects around 10% of women of reproductive age. The gold standard of diagnosing this condition is laparoscopy. This investigation can identify areas of ectopic endometrial tissue, adhesions, peritoneal deposits, and endometrial deposits on the ovaries. Chocolate cysts may be visualized during the procedure. Hysteroscopy will not play a role here, as endometriosis refers to growth of endometrial tissue outside the womb. Hysteroscopy will only involve investigation of the womb itself. MRI pelvis is sometimes used and is useful for imaging the entire abdomen and pelvis, but its specificity and sensitivity varies depending on the location of the disease. Transabdominal ultrasound is not gold standard diagnosis for endometriosis. It would not allow for adequate visualization of the ectopic endometrial tissue. Although transvaginal ultrasound is often requested in primary care as an initial investigation, is not adequately reliable or accurate enough to diagnose endometriosis. Okay, I think it's quite straightforward, this one. Next question. A 53-year-old woman presents with urgency and frequency. 2 weeks ago, she consulted a colleague as she felt dry during intercourse. She has been treated for urinary tract infections on multiple occasions in the past, but urine culture is always negative. Her only medication is continuous hormone replacement therapy. A vaginal examination is performed, which shows no evidence of vaginal atrophy and no masses are felt. An ultrasound is requested. Both kidneys, spleen, and liver are normal size. Outline of bladder normal. 5 cm complex ovarian cyst noted on the left ovary. Right ovary and uterus normal. What is the most appropriate next step? Well, at first, when they said dry during intercourse, thought maybe something wrong with the glands, maybe Sjogren's syndrome, causing not enough secretion. However, based on ultrasound findings, that's a 5 cm. It's not a simple ovarian cyst, it's a complex ovarian cyst, so probably it's loculated. It's not homogeneous. So in a 53-year-old woman with unspecific symptoms, and you find an complex ovarian cyst, it's better you investigate further, so to make sure it's not an ovarian cancer. Refer for urodynamics, that's for urinary function. There's no complaint of urinary function here. Pelvic floor muscle training, there's no incontinence here. Trial of topical estrogen, it might help if it's due to menopausal symptoms, but in this case there's no vaginal atrophy, so unlikely. Urgent referral to gynecology is required, I think, because you're suspecting ovarian cancer here. Yeah, so any ovarian mass in a postmenopausal woman needs to be investigated. So ovarian enlargement management. The initial imaging modality for suspected ovarian cysts or tumors is ultrasound. This report will usually report the cyst is either simple, unilocular, more likely to be physiological or benign, or complex, multilocular, more likely to be malignant. Management depends on the age of the patient and whether the patient is symptomatic. It should be remembered that the diagnosis of ovarian cancer is often delayed due to vague presentation. Premenopausal women, a conservative approach may be taken for younger women, especially if less than 35 years, as malignancy is less common. If the cyst is small, for example less than 5 cm, and reported as simple, then it's highly likely to be benign. A repeat ultrasound should be arranged for 8 to 12 weeks and referral considered if it persists. Postmenopausal women, by definition, physiological cysts are unlikely. Any postmenopausal woman with an ovarian cyst, regardless of nature or size, should be referred to gynecology for assessment. Okay, so even if it's a simple cyst, even if it's less than 5 cm, if postmenopausal, you would refer to gynecology, because Yeah, postmenopausal shouldn't be having any more functional cysts. Next question. A 32-year-old man undergoes an appendicectomy. So removed his appendix. A large carcinoid tumor is identified and a completion right hemicolectomy is performed. He is well for several months and then develops symptoms of palpitations and facial flushing. So that's recurrence of his tumor. Which of following diagnostic markers should be requested? So we just went through this earlier, I think. So it's urinary 5-HIAA. Yep, for carcinoid syndrome. Right, straightforward because we went through this already. Next question. You are a general practitioner. Your patient, Miss Ramsden, had her first seizure 2 days ago. You tell her she must stop driving and that you need to inform the driver and vehicle licensing authority, DVLA. Miss Ramsden becomes very annoyed. She refuses to stop driving and does not want you to inform the DVLA. Miss Ramsden believes her medical information should be kept confidential. What's the most appropriate course of action? So, though she thinks confidentiality is important and confidentiality is important, however, she's a danger to other people on the road, so I think it's your responsibility to inform the DVLA. Right, confidentiality is important until it can be overridden by risk to self or risk to other people. So discuss the situation under the colleague, respect the patient's confidentiality, only inform DVLA if patient has had a seizure, inform DVLA after patient has been followed up, from DVLA straight away. I think, unless I'm wrong about the first seizure not needing DVLA, right, so it does need. GMC guidelines state that confidential medical care is recognized in law as being in the public interest. However, they can also be public interest in disclosing information to protect individuals or society from risk of serious harm. There's a risk to public safety if Ms. Ramsden were to have a seizure while driving a car. Therefore, the VLA need to be informed against her wishes, especially because she is refusing to stop driving. So the VLA on neurological disorders, the guidelines below relate to car or motorcycle use unless specifically stated. For obvious reasons, the rules relating to drivers of heavy goods vehicles tend to be much stricter. Epilepsy or seizures, all patients must not drive and must inform the DVLA. First, unprovoked or isolated seizure, 6 months off if there are no relevant structural abnormalities or brain imaging and no definite epileptiform activity on EEG. If these conditions are not met, then this is increased to 12 months. For patients with established epilepsy or those with multiple unprovoked seizures may qualify for a driving license if they have been free from any seizure for 12 months, if there have been no seizure for 5 years, till 70 license is usually restored. Withdrawal of epilepsy medication should not drive whilst anti-epileptic medication is being withdrawn and for 6 months after the last dose. Okay. Syncope, simple faint, no restrictions. Single episode unexplained and treated, 4 weeks off. Single episode unexplained, explained and treated, 4 weeks off. Unexplained, 6 months off. 2 or more episodes, 12 months off. Other conditions, stroke or TIA, 1 month off driving, may not need to involve DVLA, but if no residual neurological deficit. Multiple TIAs over short periods of times, 3 months off driving and inform DVLA. Craniotomy, for example, meningioma, 1 year off driving. Pituitary tumor, craniotomy, 6 months. Transphenoidal surgery can drive when there's no debarring residual impairment likely to affect safe driving. Narcolepsy, cataplexy, cease driving on diagnosis, restart once satisfactory control of symptoms. Chronic neurological disorders, multiple sclerosis, motor neuron disease, DVLA should be informed. Complete PK1 form application for driving license holders, state of health. So, if there's a seizure, 6 months. There's seizure, epileptic things or structural things detected, then 12 months. Change drugs, 6 months. You can 12 months. I mean, if you want to withdraw the drugs, 6 months after the last dose, and then if you want to drive a year on anti-epileptic and then you have no seizures for 12 months, you can drive. 5 years without seizures, you can get a more like a permanent license restored. Alright, next question. A 26-year-old male with past medical history of COPD due to alpha-1 antitrypsin deficiency presents to emergency department with pleuritic chest pain. The team performs a chest X-ray that shows a pneumothorax with a rim of 0.8 cm. Visual flowing would be the appropriate management plan. So the secondary pneumothorax, thickness is 0.8 cm. I think there are guidelines about this, but I can't remember it. Visual flowing would be appropriate management plan. Okay, so I need to memorize the guidelines. I think secondary pneumothorax you need to admit and it's a chest drain. But then it's 0.8 cm only. How about giving oxygen admit for 24 hours? Do you need to insert chest drain? 14 gauge cannula. Lifestyle advice. Discharge should be wrong lah, because secondary I think I remember need to admit. Just whether need to chest drain or not. Can't remember. I'm gonna go with the last one. Yeah, that's the correct answer. But I just guessed it, so I have to study actual guidelines. In a secondary pneumothorax less than 1 cm, admit and give oxygen for 24 hours and review. The correct answer is to give oxygen and admit him for 24 hours. Don't be tricked by the young age of this patient, given the past medical history is suffering from a secondary pneumothorax. British Thoracic Society guidelines state that in secondary pneumothorax less than 1 cm, you should admit and give oxygen for 24 hours and review. This is indicated because usually patients will have an already deranged respiratory function due to their disease. Discharge and follow-up as an outpatient is indicated in patients with primary pneumothorax with a rim of air less than 2 cm. Discharge with lifestyle advice is not an option for any pneumothorax. But lifestyle advice should be given anyway, such as avoid smoking, reduce the risk of further episodes. Insertion of chest drain is appropriate in secondary pneumothorax. The patient is more than 50 years old, and the rim of air is more than 2 cm, and/or the patient is short of breath. An attempt to aspiration with a 14 gauge cannula is done in a patient with primary pneumothorax and rim of air more than 2 cm. Okay, so aspiration is for primary pneumothorax more than 2 cm. Chest drain is for secondary pneumothorax more than 2 cm. Let's look at the, oh, it's not here, huh? I think it's here. Is this the guidelines? Is this the guidelines? Oops. I think this is the guidelines. Yeah, this is the guidelines here. So spontaneous pneumothorax. Oops. BTS, huh? This is the full one. Not seeing this one. It doesn't have an algorithm. I think the algorithm should be part of this. Yeah, I think I saw it just now. But yeah, so it's more colorful, nice algorithm. Spontaneous pneumothorax, if bilateral or hemodynamically unstable, proceed to chest drain. If age more than 50 and significant smoking history, evidence of underlying lung disease on exam or chest x-ray, yes, it's a secondary pneumothorax. So if age more than 50, significant smoking history, you would straight away consider it as secondary, or as underlying lung disease. That is secondary. More than 2 cm if secondary, you give a chest drain. Chest drain. And admit. If 1 to 2 cm, you aspirate. 16 to 18 gauge. 14 gauge can also, I guess. Smaller the number, the bigger the gauge anyway. Success. Size now less than 1 cm. Admit high flow oxygen for observe for 24 hours. If less than 1 cm, yeah, just admit for high flow oxygen, that's all. 1 to 2 aspirate. More than 2 chest drain. Straight away. Okay, and then if it's primary pneumothorax, means it's less than 50 years old, non-smoker, no underlying chest lung disease or chest X-ray abnormalities. You can, if size is more than 2 cm, you can aspirate. And if successful aspiration less than 2 cm, breathing improve, can consider discharge. Review in outpatient in 2 to 4 weeks. If it's not successful, then chest drain. Yeah. Okay, so primary pneumothorax. Okay, first, whether he has symptoms or not, right? Up here, spontaneous pneumothorax, hemodynamically unstable or bilateral. If it's hemodynamically unstable, out of breath, bilateral, you would straight away proceed to chest drain. If not, then you want to see whether it is a primary or secondary pneumothorax. Secondary pneumothorax means if the patient is more than 50 years old and he's a smoker, then you would straight away assume that it's a secondary pneumothorax, or he has underlying lung disease, for example, alpha-1 antitrypsin deficiency, or on chest X-ray you see some lung abnormalities, for example, he has COPD, and you would say it's a secondary pneumothorax. Otherwise, if it's a young patient, non-smoker, no underlying lung disease, then it's primary pneumothorax. For secondary pneumothorax, you have 3 routes. If it's more than 2 cm, you straight away do a chest drain. If it's 1 to 2 cm, you will attempt aspiration. And if it's less than 1 cm, you will still admit and monitor for 24 hours, give oxygen. And then for primary pneumothorax, you only have 2 routes. For primary pneumothorax, you have, if it's more than 2 cm, then you would aspirate. And if it's less than 2 cm, then you would just discharge and follow as an outpatient. Yeah, okay, try to remember that. Next question. Which one of the following is the main criteria for determining whether a patient with chronic obstructive pulmonary disease, COPD, should be offered long-term oxygen therapy? LTOT. I forgot. This is like memorizing guidelines again. So I think it's 2 ABG measurements. PO2 of less than 7.3. Just guessing here. Yeah, that's correct. So COPD, long-term oxygen therapy if 2 measurements of PaO2 less than 7.3. And normal PaO2 is 10 to 14 kPa, I think. So less than 7.3 on 2 ABGs, you can consider it LTOT. Here, let's look at some notes on COPD long-term oxygen therapy. The 2018 NICE guidelines on COPD clearly define which patients should be assessed for and offered long-term oxygen therapy, LTOT. Patients who receive LTOT should breathe supplementary oxygen for at least 15 hours a day. Oxygen concentrations are used to provide a fixed supply for LTOT. Assess patients if any of the following: very severe airflow obstruction, FEV1 less than 30% predicted. Assessment should be considered for patients with severe airflow obstruction, FEV1 30 to 49% predicted. Cyanosis, polycythemia, peripheral edema, raised jugular venous pressure, oxygen saturation less than or equal to 92% on room air. Assessment is done by measuring arterial blood gases on 2 occasions, at least 3 weeks apart, in patients with stable COPD on optimal management. Offer LTOT to patients with a PaO2 of less than 7.3 kilopascals or those with a PaO2 of 7.3 to 8 kilopascals and one of the following: secondary polycythemia, peripheral edema, pulmonary hypertension. In terms of smoking, NICE advice the following: do not offer LTOT to people who continue to smoke despite being offered smoking cessation advice and treatment, and refer to specialists to stop smoking services. because there's a danger of the cigarette lighting the oxygen tank on fire and causing an explosion and burning the house down, killing the whole family. NICE suggests that a structured risk assessment is carried out before offering LTOT, including the risk of falls from tripping over equipment, the risk of burns and fires, and increased risk of these people who live in homes where someone smokes, including e-cigarettes. Okay, so there you have it. Less than 7.3 kilopascals for 2 ABG measurements, at least 3 weeks apart, or 7.3 to 8 kilopascals with secondary polycythemia or peripheral edema or pulmonary hypertension. Right, next question. A 76-year-old man is seen by his GP. He recently had an ambulatory blood pressure monitor which showed frequent readings above 160/95. That's very high. The man has a background of well-controlled heart failure, New York Heart Association stage 2, NYHA stage 2, and chronic kidney disease. He takes ramipril, bisoprolol, and atorvastatin. He has been established on this regime for 1 year, and those doses have been optimized. What would be the most appropriate next step? So you want to control his hypertension, right? He's already on ramipril, bisoprolol, and atorvastatin. Ramipril is cardioprotective. It prevents heart remodeling, and it also reduces blood pressure. Bisoprolol is a beta blocker, I think. It reduces the workload of the heart, and it also reduces blood pressure. What other blood pressure medications can we give? Right? Indapamide is a thiazide-like diuretic. We can give it, I think. I'm not very sure. Nifedipine is a calcium channel blocker. We can give that too, I think. I'm not very sure. Continue to monitor and review in 1 month. I probably want to do something about that blood pressure already because it's an ambulatory blood pressure, not just a clinic reading. Stop ramipril and trial amlodipine. No reason you want to stop amlodipine. No reason you want to stop ramipril, right? So, I think the answer might be between first and second choices. Add indapamide or add nifedipine. Nifedipine, I think. Is it a DHP or non-DHP? Which is which? I remember already. I think it's a DHP. So it shouldn't. Verapamil is a DHP. Is nifedipine a DHP? I don't know. If it is a DHP, you shouldn't be using it with bisoprolol. So the answer would be adding a indapamide. I'm gonna guess indapamide. Yeah, that's the correct answer. Poorly controlled hypertension, already taking ACE inhibitor, add a calcium channel blocker, or a thiazide-like diuretic. The correct answer is to commence indapamide in addition to ramipril. This patient has stage 2 hypertension on ambulatory monitoring, established on an ACE inhibitor as per NICE treatment algorithm. The next step would be to add a calcium channel blocker or a thiazide-like diuretic. Adding nifedipine is incorrect. Nifedipine should be avoided in heart failure due to risk of symptom exacerbation. Amlodipine is the only calcium channel blocker licensed for use in heart failure. Okay, so something to remember here. Nifedipine not used in heart failure, risk of symptom exacerbation. Okay, only amlodipine can be used for heart failure. Continuing blood pressure monitoring at home and reviewing in 1 month would not be appropriate. The patient has already been monitoring blood pressure at home and with the evidence of persisting hypertension in addition to with other cardiovascular risk factors, treatment of his hypertension should be escalated. Stopping ramipril and trialing amlodipine instead is incorrect. Amlodipine could be added in addition to ramipril, but not in replacement of it. Combination therapy is the recommendation as per the treatment algorithm. Stopping ramipril and trialing amlodipine with indapamide instead is incorrect. A calcium channel blocker or thiazide diuretic can be added in addition to ACE inhibitor, but the combination should not be commenced in replacement of an ACE inhibitor. Okay, so I want to know if nifedipine is a DHP or a non-DHP, and what's a DHP, what's a non-DHP? Dihydropyridine. So nifedipine, dihydropyridines including nifedipine is potent vasodilators. So DHPs are the ones that are not really affecting the heart. Dihydropyridines include amlodipine, nifedipine, clevidipine, and felodipine. Non-dihydropyridines such as verapamil and diltiazem. Okay, remember verapamil and diltiazem are non-DHPs and affect the heart more than DHPs. DHPs don't affect the heart much. Non-DHPs affect the heart more. DHPs don't affect the hearts much. Okay, D for don't affect the hearts much. Non-DHPs affect the heart more. Non-DHPs includes verapamil and diltiazem. Nifedipine is actually a DHP, but it shouldn't be used in heart failure because it can worsen the symptoms. Right, next question. Which one of the following interventions is most likely to be beneficial in a patient with schizophrenia? Counseling, supportive psychotherapy, social skills training, adherence therapy, cognitive behavioral therapy. I think NICE guidelines kind of advocates cognitive behavioral therapy a lot, so probably it's the most likely to be beneficial. Yep. Schizophrenia management. NICE published guidelines on the management of schizophrenia in 2009. Key points. Oral atypical antipsychotics are first line. Cognitive behavioral therapy should be offered to all patients. Close attention should be paid to cardiovascular risk factor modification due to the high rates of cardiovascular disease in schizophrenic patients linked to antipsychotic medication and high smoking rates. Okay, so ask them to stop smoking, exercise more, eat less fat, control your diet, things like that. Right, next question. You review a 42-year-old woman 6 weeks following a renal transplant for focal segmental glomerulosclerosis. Following the procedure, she was discharged on a combination of tacrolimus, mycophenolate, and prednisolone, all immunosuppressants, I think. She has now presented with a 5-day history of feeling generally unwell with anorexia, fatigue, and arthralgia. 5-day history, huh? On examination, her sclera are jaundiced and she has widespread lymphadenopathy with hepatomegaly. What's the most likely diagnosis? So she had a renal transplant, now is having hepatic symptoms. Jaundice, widespread lymphadenopathy, hepatomegaly. It could be let's see the options. Hepatitis C. Well, usually it is in IVDUs. Could have gotten it from the transplant, but usually I will screen it first, right? EBV. I don't know if EBV could cause hepatitis like this. HIV. HIV would present with, I don't know, it should be flu-like illness first, a seroconversion first, right? But then she is immunosuppressed, so I don't know whether it's typical seroconversion or not. It doesn't typically cause hepatitis. It doesn't usually cause liver inflammation like this, I guess. Hepatitis B could be also cytomegalovirus. I'm the most suspicious of, because she is very immunosuppressed, and I think cytomegalovirus can cause acute liver pathology. I'm not sure what to say. It's more of a gut feeling that it's cytomegalovirus. I might be wrong. I'm just gonna guess. Yeah, it's correct. So cytomegalovirus is the most common and important viral infection in solid organ transplant recipients. Again, cyclovir is the treatment of choice in such patients. Renal transplant HLA typing graft failure. The human leukocyte antigen HLA system is the name given to the major histocompatibility complex MHC in humans. It is coded for on chromosome 6. Some basic points on the HLA system. Class 1 antigens include A, B, and C. Class 2 antigens include DP, DQ, and DR. When HLA matching for renal transplant, the relative importance of HLA antigens are as follows. DR bigger than DB, bigger than A. Okay, graft survival, 1 year 90%, 10 years 60% for cadaveric transplant, 1 year 95%, 10 years 70% for living donor transplants. Post-op problems, tubular necrosis of the graft, vascular thrombosis, urine leakage, UTI. Hyperacute rejection minutes to hours due to pre-existing antibodies against ABO, HLA antigens. An example of type 2 hypersensitivity reaction leads to widespread thrombosis of graft vessels, ischemia, and necrosis of the transplanted organ. No treatment is possible and the graft must be removed. Acute graft failure, which is in this case less than 6 months. This one happened within the 6 weeks. So there is acute graft failure. Usually due to mismatched HLA, cell-mediated cytotoxic T cells. Other causes include cytomegalovirus infection, may be reversible with steroids and immunosuppressants. Causes of chronic graft failure more than 6 months, both antibody and cell-mediated mechanisms cause fibrosis through the transplanted kidney, chronic allograft nephropathy, recurrence of original renal disease, MCGN. Something glomerulonephritis, mesenteric capillary, and something. Mesenteric capillary, glomerulonecrosis, glomerulonephritis, more than IgA nephritis, more than F, focal segmental glomerulosclerosis. I think mesenteric capillary or something like that. I think worth looking at each of these videos to get a better understanding.
Cytomegalovirus, or CMV, is an enveloped, double-stranded DNA virus that belongs to the herpes viridae family. It's one of the most common viruses to cause severe infection in individuals undergoing transplantation of bone marrow or solid organs like the liver or kidney. It can affect almost every organ in the body, resulting in encephalitis, retinitis, pneumonia, hepatitis, gastroenteritis, and of course, transplant rejection. In the post-transplantation period, the recipient is usually given immunosuppressive medication in order to prevent their immune system from recognizing the transplanted tissue as foreign and causing rejection. However, one major disadvantage of this approach is that the weakened immune system is unable to protect the body against pathogens like CMV. CMV can be transmitted through blood and other body fluids like saliva, genital secretions, and urine of an infected person, or from the transplanted organ itself. During the primary infection, the virus usually invades the epithelial cells, like those that make up the oral, GI, or urinary mucosa, and it starts to multiply. CMV damages the infected cells by breaking down the cytoskeletons which maintain the cell structure. That results in enlarged cells with intranuclear viral inclusion bodies, giving it the typical owl's eye appearance. CMV also infects monocytes in the blood and sets up a latent infection, which means that the virus remains dormant for long periods of time. The dormant virus can then reactivate at times when the immune system weakens, causing disease. Most of the time, primary infection occurs years before the transplant, with resultant reactivation of the virus during immunosuppressive therapy. In about 25% of transplants, primary infection occurs, which is usually much more severe compared to reactivation. In either case, the virus can spread throughout the body, damaging various organs. The transplanted organ is almost always affected. This is because viral infected cells attract an army of immune cells to the site, which in the process of killing the virus also recognize the foreign transplanted cells and may attack them, causing collateral damage. If it spreads to the liver, it can cause viral hepatitis, which is the inflammation of the liver. If the virus moves into the lower respiratory system, it can cause pneumonia. It can also affect epithelial cells of the GI tract, particularly those of the esophagus and large intestine, causing gastroenteritis. In rare cases, CMV can also affect the retina, causing retinitis, and the brain, causing encephalitis. Symptoms usually begin 1 to 4 months after the organ transplantation in the absence of antiviral prophylaxis. In the setting of prophylaxis, the onset, when it occurs, is usually within 6 months of discontinuation of prophylaxis. Depending on the organ transplanted, symptoms, when they occur, are generally accompanied by fever and malaise. Pneumonia can cause symptoms of cough and shortness of breath. Gastrointestinal symptoms include pain and difficulty while swallowing, abdominal pain, nausea, vomiting, and diarrhea. In addition, hepatitis can cause jaundice. Retinitis presents with blurring of vision, dark spots in the visual field called scotomas, or even total blindness. Encephalitis presents with symptoms like altered mental status, seizures, and weakness. Diagnosis of CMV infections involves isolation of the virus from tissues and body fluids, polymerase chain reaction, or PCR, to detect viral DNA, and serological tests like immunofluorescence assays to detect CMV-specific antibodies in the blood. Increased CMV IgM titer may indicate acute infection, and increased CMV IgG titer indicates past infection. Specific DNA studies are more sensitive and specific than antibody studies. As of now, there is no cure for CMV infections, but they can be treated with the help of antiviral medications like ganciclovir, valganciclovir, and foscarnet. Also, CMV IVIG, or intravenous immunoglobulin, which contains anti-cytomegalovirus antibodies, can be given to help boost the immune response. Now, in high-risk individuals, like those with a previous history of CMV infection, prophylactic antiviral therapy can be given after the transplant to prevent reactivation. Alright, as a quick recap. Cytomegalovirus, or CMV, is one of the most common viruses to cause severe infection in transplant recipients receiving immunosuppressive medication. It can affect almost every organ in the body, resulting in encephalitis, retinitis, pneumonia, hepatitis, gastroenteritis, and transplant rejection. Symptoms vary based on the organ affected. CMV is diagnosed with the help of PCR and serological testing of tissues and body fluid, and it's treated using antiviral medications like ganciclovir, valganciclovir, and foscarnet, and CMV IVIG.
So CMV is most common. All these are possible, but CMV is most common. What this?
Post-transplant lymphoproliferative disorders, or PTLDs, are uncontrolled growths of cells called lymphocytes that may occur in transplant recipients after receiving a solid organ such as a kidney or a lung, or stem cells. Transplant recipients require medications to suppress their immune systems, which may contribute to the proliferative disorders, or PTLDs, are uncontrolled growths of cells called lymphocytes that may occur in transplant recipients after receiving a solid organ such as a kidney or a lung, or stem cells. Transplant recipients require medications to suppress their immune systems, which may contribute to the development of a PTLD. Normally, immune cells can differentiate between healthy self and other cells by inspecting for the presence or absence of the normal self-major histocompatibility complexes, also called human leukocyte antigens, present on the surface of every cell that contains a nucleus. Healthy self cells are left alone. Others include cells from other people or donors, and self cells that are infected, damaged, or stressed. Lymphocytes are a class of rapidly dividing cells, and therefore tends to develop mutations more often. B lymphocytes, or B cells, work to develop antibodies. B lymphocytes develop mutations more often, and therefore tends to dividing cells, a class of rapidly dividing cells, and lymphocytes are a class of rapidly dividing cells, and therefore tends to develop mutations more often. B lymphocytes, or B cells, work to develop antibodies toward invading microbes. There's also two types of T lymphocytes, or T cells. Cytotoxic T cells can directly destroy other cells, and helper T cells assist other immune cells. Normally, if B cells start to replicate out of control, it's the T cells that keep them in check and keep the immune response organized. When people receive a transplanted organ or stem cells, they also must take immunosuppressive medications to prevent the immune system from rejecting or attacking the transplant. In PTLDs, immunosuppression also prevents the destruction of abnormal lymphocytes that exhibit uncontrolled replication. Resulting uncontrolled growth of lymphocytes can either be a benign hyperplasia, meaning there's a large collection of non-cancerous cells, or the cells can become malignant, resulting in a cancer called lymphoma. While PTLD may result from the overproduction of T cells, it is more typically associated with the overproduction of B cells. One cause of PTLD is Epstein-Barr virus, which is contracted early in life by most people through contact with infected saliva. It lies dormant in B cells and can reactivate either inside the recipient's B cells or from donor B cells that catch a ride inside solid organs or stem cell transplant vials. Because of the immunosuppressive medications, T cells are unable to stop B cells from replicating. Signs and symptoms of PTLDs can range from a small mass within a lymph node anywhere in the body to much larger masses, along with the constitutional B symptoms of fevers, weight loss, and night sweats that are seen in malignant lymphomas. Widespread metastasis can lead to severe dysfunction of any affected tissue. Risk factors include the type of immunosuppressive medication used and the degree of immunosuppression that it causes, whether or not the person has antibodies to Epstein-Barr virus, fewer similarities between the donor and recipient major histocompatibility complexes, previous development of cancer, and being younger. Diagnosis of PTLDs may include blood tests, tissue biopsies to determine what type of cancer is present, and imaging such as a PET or CT scan to help determine whether the cancer has spread to other sites in the body. Treatment aims to eliminate the PTLD while minimizing harm to the transplant and may include surgery, radiation therapy, and chemotherapy. If the cancer is caused by B cells that produce the surface protein CD20, a manufactured antibody called rituximab may be used. There are several potential therapies for these conditions that are currently in the investigational stages of development. Alright, as a quick recap, post-transplant lymphoproliferative disorders, or PTLDs, are uncontrolled growths of lymphocytes that occur after someone has received a solid organ or stem cell transplant that requires immunosuppressive medications to prevent transplant rejection. They can originate in either type of lymphocyte, B cells or T cells. Diagnosis involves blood tests, a biopsy, and imaging, while treatment may include surgery, chemotherapy, and radiation.
Graft versus host. Host versus graft. Graft versus host. Graft versus host is usually because bone marrow transplant. Host versus graft is because other organ transplant that doesn't have human cells. Right.
On our YouTube channel, you'll find a limited selection of pathology and patient videos. With Osmosis Prime, you'll get access to over 700 videos, including complete coverage of pathology and physiology, and a growing
With graft versus host disease, graft refers to a section of transplanted or donated tissue like the bone marrow or peripheral blood, and host refers to the tissues of the person receiving the transplant. In this disease, immune cells in the donated tissue attack the recipient's body cells. Normally, the immune system's job is to fight against anything foreign that might cause harm, without harming the body's own cells. To make that work, the immune system cells are trained early on to distinguish the body's own cells, called self cells, from foreign cells, called non-self cells. Recognizing whether the cell is foreign or not involves a set of genes called the histocompatibility genes, which make up the major histocompatibility complex, or MHC proteins. These MHC proteins also go by the name human leukocyte antigens, or HLA. The histocompatibility genes actually code for two classes of proteins, MHC class 1 and MHC class 2. MHC class 1 molecules are found on all nucleated cells throughout the body, while MHC class 2 molecules are only expressed on antigen-presenting cells like monocytes, macrophages, dendritic cells, and B cells. But because the genes coding for them are so variable in the population, two different individuals will have major differences in the antigens expressed on their cells, even siblings, unless of course they're identical twins. When surgeons do a tissue transplantation, the transplant usually comes from a different person with different genes, and it's called an allograft. If there are immune cells within that allograft, they will see the MHC proteins that coat every cell of the recipient body as foreign. In fact, that's why transplantation donors are really carefully selected to make sure that they share as many of the same HLA antigens with the host as possible. But even between HLA identical individuals, other antigens, called minor histocompatibility antigens, can be recognized as foreign and trigger an immune response between the donor and the recipient. In graft versus host disease, there are three key elements. First, the graft must contain immune cells. This is usually the case in hematopoietic stem cell transplantations, which contain hematopoietic stem cells that can give rise to all types of blood cells, including immune cells. Now, hematopoietic stem cells are derived from bone marrow, which is the spongy tissue inside bones where new blood cells are formed. Alternatively, hematopoietic stem cells can come from the peripheral blood or umbilical cord blood from a newborn baby. Typically, hematopoietic stem cell transplantations are needed by individuals whose own bone marrow doesn't function properly. For example, those suffering from leukemia. The second element is that the host's immune system must be suppressed so that it doesn't destroy the grafted immune cells, giving the grafted immune cells enough time to mount an attack. And the final element is that the host must be immunologically different from the donor. In other words, the host's histocompatibility antigens, mainly the HLA antigens, must appear as foreign to the grafted immune cells. The second element is that the host's immune system must be suppressed so that it doesn't destroy the grafted immune cells, giving the grafted immune cells enough time to mount an attack. And the final element is that the host must be immunologically different from the donor. In other words, the host's histocompatibility antigens, mainly the HLA antigens, must appear as foreign to the grafted immune cells. So, shortly after transplantation, the host dendritic cells, which usually hang out in various host tissues like the lining of the skin, might pick up antigens from that tissue and travel to the nearest lymph node, where a lot of the immune cells coming from the donor live. So that's where they meet with the helper T cells and present those antigens upon their MHC class 2 molecules. If the donor helper T cells recognize these antigens as foreign, they differentiate into type 1 helper T cells, or Th1 cells. Th1 cells then start releasing the cytokines interleukin-2 and interferon gamma, which help both of them and other T cells in the area proliferate. At the same time, these cytokines induce the expression of more MHC class 2 molecules on the surface of the host cells, which makes it easier for the donor's helper T cells and the host antigen-presenting cells to interact with each other. Interferon gamma also activates phagocytes like macrophages, which release pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin-1, and interleukin-6, which recruits more immune cells in the area. Activated macrophages also secrete lysosomal enzymes, which directly damages tissue. In addition to helper T cells, there are also grafted cytotoxic T cells circulating in the area. These cytotoxic T cells recognize antigens presented upon MHC class I molecules, which are on the surface of all nucleated cells in the host body. As before, if these antigens are seen as foreign, the cytotoxic T cells get activated and start secreting perforin and granzymes. Perforin will perforate the target cell by forming pores, and these pores will allow granzymes to enter the cell. Once inside, the granzymes induce apoptosis, or programmed cell death. Apoptosis is also induced by the interaction between a Fas molecule, expressed on the surface of the target cell, and a protein called Fas ligand, expressed on the surface of the cytotoxic T cell. This interaction triggers a cascade of signaling events inside the target cell, eventually causing apoptosis. Overall, the combined actions of helper and cytotoxic T cells results in extensive injury of one or more tissues throughout the body. Now, the symptoms of graft versus host disease can vary wildly depending on the type of tissues affected, and it's not known why some types of tissues, usually the skin, liver, and the digestive tract, are affected more frequently and more severely than others, and why there is a correlation with time after transplant. In the first 3 months following transplantation, there's the acute form of the disease, which typically involves the skin. It causes a painful, itchy rash on the palms of the hands or soles of the feet that can peel or blister and progress to covering the whole body. After the skin, the next most common target is the liver, where the disease is usually asymptomatic, but leads to an elevation in bilirubin, alkaline phosphatase, and aminotransferases like ALT and AST. Acute graft versus host disease can also involve other parts of the digestive system, particularly the distal small intestine and colon, causing diarrhea, intestinal bleeding, and abdominal pain. If graft versus host disease persists for more than 3 months following transplantation, it's considered chronic. Once again, the skin is most commonly affected chronically, and it can cause the skin to thicken. It can also affect the eyes and lacrimal glands, causing a burning sensation and photophobia or difficulty tolerating bright light. Chronically, the proximal digestive tract can also be involved, particularly the mouth and salivary glands, causing dry mouth, sensitivity to acidic or spicy foods, and odynophagia, or pain when swallowing. Less frequently, chronic graft versus host disease can affect the lungs, causing shortness of breath and cough, and the muscles, causing muscle cramps and weakness. Diagnosis of graft versus host disease is primarily based on signs and symptoms, like a skin rash. Lab tests such as liver function tests and imaging studies like liver ultrasound are often useful to assess the damage caused to specific organs. Finally, a tissue biopsy of the affected organ can help confirm diagnosis. Treatment for both acute and chronic graft versus host disease is intravenous glucocorticoids to suppress the T-cell mediated immune response. However, these should be given in moderation in order to avoid raising the risk of infection. Alright, as a quick recap, graft versus host disease occurs when T cells of a graft react against the tissues of the graft recipient, causing a variety of symptoms according to the affected tissue, which most commonly is the skin, the liver, and the gastrointestinal tract. There's an acute form, which happens in the first 3 months, and a chronic form, which happens later than 3 months after the transplantation.
Thanks for watching. If you're interested in a deeper dive on this topic,
Right, next question. A 35-year-old woman with a history of multiple spontaneous miscarriages, is this antiphospholipid syndrome, recurrent DVTs and PEs, present to your clinic for a review appointment. On examination, notice purpuric rashes, splinter hemorrhages, and livedo reticularis. Purpuric rashes, splinter hemorrhages, livedo reticularis. What do these mean? Unlikely diagnosis. Which of the following would be the most appropriate autoimmune antibody to test to perform? So based on the first part there, we know this is antiphospholipid syndrome. So test is anti-cardiolipin antibodies or anti-Ro and anti-La. I think it's important too. Not sure which one is more important. Anti-cardiolipin antibodies is not that specific, right? Anti-Ro and anti-La might be for something else, I don't remember. Anti-Jo1 and anti-Me2 is for dermatomyositis. Anti-dsDNA is more specific for SLE. Anti-CCP is more for rheumatoid arthritis. Let's see. The answer is anti-cardiolipin antibodies. Antiphospholipid syndrome antibodies are lupus anticoagulant and anti-cardiolipin antibodies. 1 is incorrect. This is antibody test for rheumatoid arthritis. 2 is incorrect. This is the antibody test for SLE. 3 is correct. This is the antibody test for antiphospholipid syndrome. 4 is incorrect. This is the antibody test for polymyositis or dermatomyositis. Anti-Ro and anti-La is for Sjogren, is it? Okay. Thought it's more of a anti-mitochondrial and anti-SCL70. No, that's a systemic sclerosis. Okay, Sjogren syndrome, anti-Ro, anti-La. Okay. Right, so let's see a bit about the antiphospholipid syndrome. Antiphospholipid syndrome is an acquired disorder characterized by a predisposition to both venous and arterial thrombosis, recurrent fetal loss, and thrombocytopenia. It may occur as a primary disorder or secondary to other conditions, most commonly systemic lupus erythematosus. A key point to the exam is to appreciate antiphospholipid syndrome causes a paradoxical rise in the APTT. This is due to ex vivo reaction of the lupus anticoagulant antibodies with phospholipids involved in the coagulation cascade. Features include venous arterial thrombosis, recurrent fetal loss, livedo reticularis. What's that? Certain cause of rash, right? Skin symptom, net-like pattern, reddish blue skin, coloration, legs often affected. Let's see how it looks like. Okay, so this is livedo reticularis. Okay. And thrombocytopenia, prolonged APTT, other features, preeclampsia, pulmonary hypertension. Associations other than SLE, autoimmune disorders, lymphoproliferative disorders, phenothiazines. Management based on EULAR guidelines, primary thromboprophylaxis, low-dose aspirin, secondary thromboprophylaxis, initial venous thromboembolic events, lifelong warfarin with target INR of 2 to 3, recurrent venous thromboembolic events, lifelong warfarin if occurred whilst taking warfarin, or consider adding low-dose aspirin, increase target INR to 3 to 4. Arterial thrombosis should be treated with lifelong warfarin with target INR 2 to 3. You look at this video. Remember it being quite good, and there's so many upvotes. It's worth looking through, I guess.
So it brings me to the second half of this short talk. And it comes from this little book, The Big Three again. Doctor, do you have any patients with migraine and headache, DVT, recurrent miscarriage or pregnancy loss, memory loss, or young strokes? These are all features of the Hughes syndrome, or the media call this sticky blood. We gave it the title antiphospholipid syndrome, now known as APS, but it's not strictly true. It's not antiphospholipid. It's, as usual, more complicated. It's an antibody against phospholipid protein complex. What are the main pointers of the Hughes syndrome? Number 1, teenage migraine. So important and so common. A tendency to thrombosis, as in Our Lady from Boston. Thrombosis, interestingly, in arteries as well as veins. Strokes, memory loss, TIAs, recurrent miscarriage, and cold circulation, blotchiness, livedo. These are all pointers if you're looking for this diagnosis. Other clues to diagnosis, and I'm going to mention these this afternoon: ataxia, giddiness, visual disturbances, atypical multiple sclerosis, and I want to spend some time coming back to that because some of these patients are wrongly labeled as MS. They can get venous ulceration. Very occasionally, not commonly, they can have low platelets. More commonly, borderline platelet counts, 110,000, very much more common. I mentioned that they get arterial. Remember, other clotting disorders like factor V Leiden is venous. But these patients, tragically, can get arterial thrombosis, and they can get heart murmurs. Remember that. If you look at patients with DVTs attending your busy outpatient clinic, and there have been a number of studies, up to 30% are positive for antiphospholipid antibodies. So really worth screening DVT for sticky blood. The biggest positive, and I'm going to spend a little time on this, is in pregnancy. What happens, we think, predominantly is that the sludging of sticky blood or the platelets adhering to each other, whatever the mechanism, affects the placenta and the brain, very commonly. And the baby doesn't get enough circulation, fetal death, and you get a miscarriage. And this is one of the commonest causes. In fact, it's the commonest treatable cause of recurrent miscarriage. And it's lovely. Once a year we have a party now in St. Thomas's Hospital for women who've had recurrent miscarriages. Some of these women, 12, 14 miscarriages. And they have successful pregnancies on either aspirin or heparin, which I'm going to speak about later. And so we have this party every year, which is quite fun for some. It's jelly and ice cream and vomiting and, usual stuff. What about the tests in Hughes syndrome? Well, unfortunately, you need 2 tests, possibly 3. You have to tick 2 boxes because not all patients have anticardiolipid antibodies. 10, 20% are negative for ACL, but they have this other dreadful test called the lupus anticoagulant, which is not lupus, it's not an anticoagulant, but the name has stuck. And so you need to tick both boxes in case you miss some patients. And in the last decade, there's a new test called anti-beta 2. This is a protein very much involved, which I'll mention briefly in a minute. What if the test is positive? Well, anticardiolipin predicts 80% of cases. Lupus anticoagulant, 30 to 40% of cases. And the lupus anticoagulant test is one of these horrible hematology tests where they add in bits of snake venom and pepper and salt and, all that stuff. So the tests should be done together if you're ticking the boxes and looking for this syndrome. What's the history, briefly, of the antiphospholipid syndrome? Well, as you've heard from the chairman, it was in 1983 that we wrote up our first big series. And this is the October 83 paper. It was called Thrombosis, Abortion, Cerebral Disease. Even then, to us, this was central. And the lupus anticoagulant. We described in that year, I think it was 170 patients. And these were the highlights for us. They got arterial disease. One of our first patients was played for Leicester Rugby Club, a very major player, and he had an arterial thrombosis and lost his leg. Neurological features, chorea, movement disorders, and seizures. Think about that. Livedo reticularis, which I'm going to show some of these pictures. Recurrent pregnancy loss, borderline platelet count. But one thing that we found very, very important, and it's a lesson that really perhaps is hard to get across, that this actually, although it overlaps with lupus, is distinct from lupus. Many people out there in Melbourne walking around with Hughes syndrome who do not have lupus. We also set up the assay for antiphospholipid antibodies and published that, as you heard, in the November Lancet, the antiphospholipid or anticardiolipin test.
Learning medicine is hard work, so much more. Try it free today. In antiphospholipid syndrome, individuals produce antiphospholipid antibodies, which attack the phospholipids in the cell membrane of their own cells, or attack proteins that are bound to those phospholipids. So antiphospholipid syndrome, or APS, is an autoimmune disease. Antiphospholipid syndrome can be primary or secondary. Primary antiphospholipid syndrome happens by itself, whereas secondary antiphospholipid syndrome happens with other autoimmune diseases, especially systemic lupus erythematosus. And just like most autoimmune diseases, antiphospholipid syndrome is more common in young females. The exact cause of antiphospholipid syndrome isn't known, but there are some known genetic and environmental factors. For example, the HLA-DR7 gene encodes a specific type of protein called the major histocompatibility complex, or MHC class II, which sits on the surface of the B cell. These surface proteins help activate B cells so that they can start producing antibodies. Now, having a mutated HLA-DR7 gene predisposes individuals to activate B cell production of antiphospholipid antibodies. But the presence of the mutated HLA-DR7 gene alone isn't enough to develop antiphospholipid syndrome. An environmental trigger must also be present. And there are a variety of potential triggers. Some common ones include infections like syphilis, hepatitis C, HIV, and malaria, drugs like some cardiovascular drugs, including procainamide, quinidine, propranolol, and hydralazine, or antipsychotic drugs like phenytoin and chlorpromazine. The main antiphospholipid antibody is anti-beta-2 glycoprotein 1, which targets the protein beta-2 glycoprotein 1, also called apolipoprotein H. This protein binds to phospholipids and inhibits agglutination, which is when platelets clump together to form blood clots. So when anti-beta-2 glycoprotein 1 binds beta-2 glycoprotein 1, it's not free to do its job, and that leads to clot formation. Another antiphospholipid antibody is anticardiolipin, which targets a lipid protein in the inner mitochondrial membrane called cardiolipin, which binds beta-2 glycoprotein 1. Anticardiolipin antibodies are also present in syphilis, and that causes a false positive test for syphilis. Autoantibodies might also target blood components. If platelets are targeted, it can lead to thrombocytopenia, and if red blood cells are targeted, it can lead to anemia. So the antiphospholipid antibodies lead to a hypercoagulable state, meaning that they cause thrombosis, or blood clots to form within arteries and veins. Arterial thrombosis is more common in males, and can cause a heart attack, stroke, or limb ischemia. In addition, individuals might develop Liebman-Sachs endocarditis, which is where vegetations form, which are a mixture of immune cells and blood clots, usually on the mitral valve. Venous thrombosis is more common in females, and typically presents as a deep vein thrombosis. Sometimes a part of the main clot might break free and become an embolus, which is where a blood clot travels downstream. Since lung capillaries are very small, this embolus could get stuck, causing a pulmonary embolism. This is a life-threatening situation because it literally blocks blood from getting into the lungs to pick up oxygen. Another organ with very small capillaries is the kidneys, so individuals might develop renal failure. A typical skin finding in antiphospholipid syndrome is livedo reticularis, which is caused by swelling of the venules due to clots obstructing them, and appears as a mottled purplish discoloration of the skin. Women affected by antiphospholipid syndrome tend to have pregnancy-related complications that can lead to a miscarriage. This can happen due to thrombosis leading to placental infarction. For reasons that aren't completely understood, antiphospholipid antibodies are thought to cause neurologic symptoms, like headaches and seizures. In rare cases, antiphospholipid syndrome leads to rapid organ failure due to generalized thrombosis, and this is called catastrophic antiphospholipid syndrome, and can lead to death. Diagnosing antiphospholipid syndrome requires meeting at least one clinical and one laboratory diagnostic criteria. The two clinical criteria are history of thrombosis and pregnancy complications, while the three laboratory criteria are presence of anticardiolipin, anti-beta-2 glycoprotein antibodies, or lupus anticoagulant in the blood. Now, lupus anticoagulant assay is a funny name, but it does have an explanation. It's called lupus because it was initially found in people affected by systemic lupus erythematosus. And it's called anticoagulant because it acts as an anticoagulant in vitro, even though it's a procoagulant in vivo. This is because phospholipid-rich platelets, which are only found in vivo, are needed to activate coagulation factors and cause a clot. In vitro, on the other hand, which is tested using the lupus anticoagulant assay, the individual's plasma is mixed with normal pooled plasma and clotting time is assessed. The pooled plasma doesn't have many phospholipid-rich platelets, so individuals with antiphospholipid antibodies end up prolonging the clotting time. In vivo, there are plenty of phospholipid-rich platelets around, so the effect is excessive clotting. Treatment of antiphospholipid syndrome is aimed at preventing thrombosis with aspirin to inhibit platelet activation, and avoiding risk factors, like smoking and oral contraceptives. People that have a blood clot should also take warfarin as oral anticoagulant therapy. During pregnancy, warfarin can cross the placenta and have a toxic effect on the fetus, so it must be replaced by low molecular weight heparin up until 6 weeks after delivery. In people with non-thrombotic manifestations or other associated autoimmune diseases, corticosteroids might be used to help limit the immune response. And finally, if symptoms are really severe, certain immunosuppressive drugs might be used. Alright, as a quick recap. Antiphospholipid syndrome is caused by antibodies, which target the phospholipids in the cell membrane. The 3 laboratory criteria are presence of anticardiolipin, anti-beta-2 glycoprotein antibodies, or lupus anticoagulant in the blood. Individuals affected are at a higher risk of thrombosis and pregnancy-related complications. Treatment involves avoiding other risk factors for thrombosis, as well as taking lifelong aspirin, sometimes as prevention of thrombosis. People that have had thrombotic symptoms should also take warfarin, and during pregnancy, warfarin must be replaced by low molecular weight heparin.
Okay, that's all for antiphospholipid syndrome. I think I'll end the recording here. See you in the next one.